This is Doc Talk, brought to you by Plateau Medical Center. And now, Dr. Paul Conley.
Hello, I'm Dr. Paul Conley, and thank you for tuning in to another episode of Doc Talk. Today we're going to talk a little bit about the thyroid gland. The thyroid is actually a gland that sits in the middle of the neck. It's actually a gland that regulates our temperature, it regulates our heart rate, it regulates multiple things. It's kind of the body's thermostat. But unfortunately, sometimes we can develop a goiter, which is a growth, or actually nodules of the thyroid gland. Now these nodules, for the most part, are benign, and there's actually an incidence of about 50% of the general population will actually have a nodule. So I thought it would be a good idea to have Dr. Andrew Petersen come on the show. And Dr. Petersen is going to kind of guide us and lead us through the workup and how we differentiate the difference between a nodule and a cyst and whether something will be cancerous or non-cancerous. So Dr. Petersen, appreciate you coming back on the show.
Thanks for having me. Glad to be here.
So when we talk about, the thyroid gland, it is a gland, and we know that it does multiple things. Maybe you can tell us a little bit about, what role does the thyroid actually play?
Sure. So basic anatomy, basic medical school question right there. The thyroid gland, it's an endocrine gland that is butterfly shaped and sits in the front of the neck. It bridges across the trachea or the windpipe, and it's kind of in the mid-neck region. It secretes thyroid hormone along with a few other hormones, and it helps to regulate the body's metabolism. It's important for a lot of GI and gut functions, which plays with your line of work. It helps regulate gut motility, gut absorption of nutrients. Very important there. It's also important with metabolism and affects most tissues within the body. So it helps regulate blood sugar and glucose levels, as well as fat breakdown and uptake, and helps ultimately provide energy to the cells within the body. And then lastly, it's also important for brain health and brain development. So while it is important for that lifelong, it's extremely important during development as a child.
Yeah, you're exactly right. From a gastrointestinal standpoint, it definitely can affect people that may have constipation, diarrhea, and I can tell you, if I have a patient with those and they haven't had a thyroid panel, most definitely I always want to check that, because again, the thyroid is actually that organ in the body that regulates so many things, from our heart rate to our skin, dry skin, hair loss, women, especially when we think about thyroid disorders or low thyroid hypothyroidism. Think with something called Hashimoto's thyroiditis. These are people that will have constipation, dry skin, difficulty losing weight. And one thing too, metabolically, we think about is cholesterol. You get someone that has really high lipids, high cholesterol, and if their thyroid is underactive, by treating that actually will correct someone's cholesterol. So the thyroid, plays a big role and does a lot of things. But one thing is, I want to talk to you about a little bit on the show tonight is that nodule. That's the person who maybe feels something in their neck, they feel something there, they feel something like a bump or a lump. And I guess I just want to talk a little bit about what is the incidence of thyroid nodules in the population, and of that, how much or what percent of those should we be concerned about?
Sure. So really good question. Thyroid nodules are extremely common. The true incidence of them is hard to detect, but they increase in likelihood as we age in life, and the overall adult incidence is estimated to be around 50% of the adult population. A lot of patients have thyroid nodules and they don't even know about it, and they're actually clinically not important either. So you don't need to necessarily identify every nodule that exists. Nodules grow over time, and while, as you said earlier, the vast majority of them are benign, and that equals usually 90, even upwards of 95% of them that are benign, thyroid cancers do exist. They tend to be slow-growing, less aggressive versions of cancer, but there are more aggressive versions of thyroid cancer as well. So you mentioned the word thyroid nodule, and that's a scary term that not everyone knows exactly what to do with. A thyroid nodule just means a growth within the thyroid gland, and there are lots of different versions of a thyroid nodule. That could include a cyst, It could include just a hyperplastic nodule where the thyroid tissue itself has kind of become more full. Or it could be other versions of benign growths, such as an adenoma or a colloid nodule, which is the most common type of benign thyroid nodule.
So when we talk about, thyroid, nodules, and, you hear the term like multi-nodular goiter. So is that something that we see? I mean, is it something that's rare or common to have like more than one nodule in the thyroid gland or multiple nodules? Can you tell us a little bit about that?
Yeah, so it is common to have more than one nodule. Goiter is a term that just means that the thyroid gland is enlarged itself, that the thyroid gland is big for some reason. And different variants of that would include uninodular goiter, where you have a single nodule that is large, making the gland large. Or it could be that you have multiple nodules that might be smaller in size, and collectively they make the gland large. And then the third category is diffuse thyroid goiter, where you actually have no nodules, but the gland itself has just become enlarged. And that's usually seen with some version of thyroiditis like Hashimoto's, which you mentioned before, which is the most common cause of hypothyroidism, or Graves' disease, which is the most common cause of hyperthyroidism.
We don't see it so much anymore in this country, but yeah, when you think about, some textbooks and stuff, when I was going through medical school, you would see these really large pronounced goiters, and some we don't see much in this country, but iodine deficiency, the thyroid needs iodine, and so it grows, to try to compensate. And now with iodine salt and iodine supplements in our food products, we don't really typically see iodine deficiency, but typically you're thinking about, like I said, that Hashimoto's or that Graves' disease, which is an autoimmune process, and they'll have an enlarged thyroid, but they also have like the exophthalmos with their eyes and things like that. But those, of course, are not nodules. They're not cancer. Those are more goiter. But again, within the goiter, you can have nodules. It does seem like, maybe correct me if I'm wrong, it does seem like, more women than men. So can you tell me a little bit about like who is more likely to get nodules? Is it more men, more women? Is it equal amongst both?
Sure. So thyroid nodules are more common in women as a general statement. They do occur in men, but more common in females. They're also more common if you smoke. Heavy alcohol consumption increases the risk of thyroid nodules. And then anything that alters body metabolism. So if you think of your different metabolic syndromes, that's going to increase the likelihood of developing a thyroid nodule. So that includes diabetes. That includes metabolic syndrome, where you mix diabetes and hyperlipidemia. It also includes different female reproductive pathologies like uterine fibroids or polycystic ovary syndrome. Those would be examples where you would have an increased risk of developing a thyroid nodule.
So when we talk about some of the things for the workup, when a person presents and they say, hey, Dr. Petersen, I feel a growth, I think I feel a nodule. How do you work that up? Are there lab tests you do? Are there imaging tests that one does? How do you go about treating or working that patient up?
Yeah, well, I guess, the first question is, how did you find the nodule in the first place? And we kind of live in a new era of medicine where folks get different imaging studies for lots of different reasons. So we find a lot of thyroid nodules somewhat accidentally. They were noticed on an MRI or a CT scan that was done for other reasons, and in that, the neck was imaged and we found the thyroid nodule. Some thyroid nodules can be palpated on exam, however, and so you might feel a lump in your neck, bring that up to your healthcare provider and ask them about that, or they might even feel it themselves on physical exam, and that might be the first way that this thyroid nodule could be identified. So once we've identified the nodule in the first place, ultrasound imaging is the best manner of evaluating, looking at the characteristics of a thyroid nodule and measuring it. It's a superior study to CT scans. Luckily, we have ultrasounds available to us through the hospital, and they're even now becoming more and more available in the clinic setting. We have one here in my office that we're going to use later today. There's even small handheld versions of ultrasounds that we see. So ultrasound is the imaging modality that you would perform first. That would be done in conjunction with some blood work. That's just general thyroid blood levels, checking your TSH, your T3, and your T4 levels. And that just helps us understand, is the gland hyperfunctional, hypofunctional, or euthyroid, which means that it's functioning at a normal rate. Luckily, most thyroid nodules don't cause alterations in thyroid function levels. So your thyroid gland will function normally and appropriately, even if you have multiple nodules under most circumstances.
So the nodule itself actually is not part of the thyroid gland. It's not thyroid tissue, so therefore it's not actually producing thyroid hormone unless someone has, I guess, what they call a hot nodule.
Sure.
And then that's actually producing. But that person will probably have signs and symptoms of hyperthyroidism.
Correct, yeah. Under most circumstances, a nodule would not affect your thyroid levels. There are circumstances that would, like you explained, a hot nodule that is secreting extra thyroid hormone.
So I think, what I'd like to do, if it's okay with you, Dr. Petersen, is I would like, for you to demonstrate, to the viewing audience, how you in your own clinic can work that up and perform an ultrasound. Does that sound okay with you?
Yep, absolutely. We'll do that during today's show.
So I tell you what we're going to do. We're going to take a little break. We're going to take a quick break, and when we come back, Dr. Petersen is going to demonstrate how to perform an ultrasound on my neck, and we're going to see if I have any thyroid nodules. So we're going to take a quick break, and we'll be right back.
This is Doc Talk, brought to you by Plateau Medical Center.
At Plateau Medical Center, we have the newest technology, which is robotic surgery. Prior to us getting it, you would have to travel out of the area into a larger hospital. By using the robot, less pain, quicker recovery time, quicker return to normal activities, and shorter hospital stays.
This new robotic platform allows us to do what we do and do it even better, and that's only going to benefit our patients.
It's not about the technology, it's not about the robot, it's about patient outcomes.
This is Doc Talk, brought to you by Plateau Medical Center. And now, Dr. Paul Conley.
Hello, welcome back. I'm Dr. Paul Conley, and we're on Doc Talk. So I got Dr. Andrew Petersen here with me tonight. We're talking about thyroid nodules. So Dr. Petersen, before the break, we talked a little bit about the thyroid nodule. We talked a little bit about the workup, and we talked about, sometimes we do some blood tests, but then we also talked about ultrasound and imaging tests. So maybe you can kind of walk us through a little bit about the workup for that nodule.
Okay, great. So after we've done an ultrasound, we've confirmed a nodule that is present. We start thinking about when we might need to biopsy this. As we mentioned before, thyroid nodules are very common. The vast majority of them are benign, but thyroid cancers do exist. And so one of the goals of thyroid nodule management is to evaluate and rule out risk of malignancy. And the primary way that we do that is with a needle biopsy. And we can do that with ultrasound. So it is an ultrasound-guided needle biopsy. It's an office procedure. It's very easy and straightforward and well tolerated from the patient. We use an ultrasound the same way we did to identify the nodule in the first place, and we actually use that to help guide a small needle to put a little drop of local numbing medicine over top of the nodule, and then use a different needle to pull out some cells from within the nodule itself. So then we can send that to our pathologist. They can evaluate the nodule, and they use a ranking system to tell us what the risk of malignancy would be. Did that needle biopsy show very benign appearing cells with a low risk of malignancy, or did it show more concerning cells that would be a higher risk for malignancy? When we need to biopsy a nodule is based on the size of the nodule as well as the characteristics of it on the ultrasound. And there's no single feature that equals cancer or equals benign pathology, but we kind of collectively put the picture together to help guide when we biopsy nodules. So again, that includes size, characteristics on the ultrasound, and we also factor in things like our history taking, which includes family history of thyroid cancer, personal radiation exposures, which could have come through treatment for a type of head neck cancer or lymphoma, or it could have come from a environmental exposure through the environment, from having a nuclear type exposure.
Yeah, I know. We think about cancer sometimes can lead to other cancers, and I've seen that in my career where someone's maybe had a cancer where they've had head and neck radiation, either maybe to a lung nodule or proximal thyroid cancer. Esophageal cancer can lead to that. But then I think we also think about Chernobyl. We think about those children that were exposed and they've had a high increased risk of thyroid cancer. So as far as the size, if a person has a thyroid nodule and they've seen their primary care provider, what kind of numbers should someone be more concerned about coming to see you for a biopsy?
Sure. In general, under 1 centimeter, we would elect to observe and monitor the nodule with serial ultrasounds that we would do usually on a yearly basis, and just monitor it. And we wouldn't biopsy that unless there was really compelling reason, such as concerning features on the ultrasound or a strong family history. So generally, 1 centimeter and smaller, we don't biopsy those. Once nodules get larger than that, up to 1.5 centimeters, again, we're using those ultrasound features to guide us. A purely cystic lesion, we might even wait till it gets to be about 1.5 centimeters. Most nodules, once they're at 1.5 centimeters in size, we usually are going to recommend to biopsy those.
So if you don't mind, I see you got your ultrasound machine here.
Sure.
Maybe you can demonstrate, to the audience and to me, how the process goes here in your clinic.
Yep, absolutely. Let's do that. So this is the exact chair we would use. You can go ahead and get yourself comfortable and lean back. We've got the headrest purposefully leaned really far back to help kind of extend your neck. Normally I would put a little drape kind of across your chest here, but we don't want to cover up your microphone. So we just kind of expose the neck nice and easy. I'm going to raise your legs up a little bit, make you comfortable. We've already got our ultrasound gel set up with our transducer probe. I'm going to reach across you here. All right, so now we've got our ultrasound. We're going to make sure that we can kind of demonstrate how this would look on the screen. Great. So this is just a cold gel that goes on the neck. It's not painful. There's no heat or electricity that's felt through this transducer. It's really just a cold gel on the neck, and we can start looking at structures in the neck. So the first thing that I look for is the trachea, and I believe we can see on the screen. We can. So this is me using a pointer here. Trachea is this dark structure in the middle, and you can see this butterfly-shaped structure that kind of hinges around that trachea, and that's a thyroid gland. And it kind of has this static look to it, and that's normal thyroid look. So I'm going to lean over. I'm looking over on the left side of your thyroid. I'm down at the bottom edge of your thyroid gland, and I'm sliding my way up the gland, looking for any nodules. And I'm moving all the way up to the upper pole, which we're seeing in this area here, and then we lose sight of it. So I didn't see any nodules on the left side of your thyroid gland, but you might ask yourself, what is this dark circle that you see right next to the gland? That is actually the carotid artery. That is not a cyst or a nodule, and we can even confirm that by looking at it with what we call the Doppler color flow. We can see movement, and that's blood flow through that carotid artery, and we can see that beautifully right here on the image. There's very little movement happening in the gland itself. So we're going to turn that off. What else? Let's have you just bear down for a moment and see if we can see your jugular vein. There we go. So we've got this big, large, dark structure that just opened up right next to your carotid artery. That's the jugular vein, the large, you can relax and breathe again. Good. That's the large vein that's emptying blood from your head back down to the heart. And so it's a large caliber vein that's there. So that was that side of your thyroid. I'm actually just going to walk around you, and I'm going to grab a little more gel so we can look at the other side.
Well, and I can tell the audience there's absolutely no discomfort of this at all. It actually kind of feels good with this loop. So.
All right. So we're going to slide over. We were looking at the right side of your thyroid before. Now I'm sliding over to look at the left side of the gland. And we see that again. Here's the trachea. Here's the left thyroid lobe. I'm scanning down. I'm looking at the inferior aspect of the thyroid gland. I don't see any nodules. We do see a little kind of mix of dark lucencies. Those are blood vessels coming into the gland. We're sliding our way up the gland itself. Kind of scanning just back and forth. You have a small dark lucency here in the gland. I can't say that I would necessarily call that a well-defined mature nodule, but it could actually be a very early lucency that over time could be on its way to turning into a thyroid nodule. That does not look concerning to me. There are no features of that of concern, and I'm even stretching a little bit to call that a nodule. But overall, really good-looking thyroid gland on both sides. Again, we can see the carotid artery just next to it. We can see the jugular vein squeezed right in here. And then we can see the really big muscles of the neck. This is the sternocleidomastoid muscle. And we can use the ultrasound not just to look at the thyroid, but to actually look at all of the structures of the neck. We're going to slide all the way up here. We're seeing muscles of the neck in front of the vocal cords. And then we can even come up so high and start to see the salivary gland. This is the salivary spit gland right here. It's looks similar to thyroid tissue. That's a little less defined, but we can use the ultrasound to look at multiple different masses. There's a better image of the submandibular spit gland. We can use the ultrasound to look at lots of different structures within the neck. It's not limited to just the thyroid itself. Let's see if we can get this is sometimes a cool image to see your vocal cords. Let's have you talk for a moment, Dr. Conley.
Hello, testing, 1, 2, 3. Hello, testing. Testing, 1, 2, 3. Do you see my cords?
We can see a little movement of the vocal cords.
I have a thick neck.
Yeah, okay. So that's it. That right there is your thyroid ultrasound. Nice image of the entire thing. Now let's just talk briefly if you did have a nodule that we wanted to biopsy. What we would do in that instance would be same setup that we are right here. Same thing, looking at the neck with the ultrasound probe. We would use a small needle with a little bit of local anesthesia, typically lidocaine, which many people have experience with at some point, and put a little drop of numbing medicine just to the edge of the transducer here into the neck, just to take a little bit of edge off of the procedure. Very well tolerated, a little bee sting with that. And then we use another needle and similar trajectory. We would come in from the side of the transducer, and I could actually see it on the ultrasound and guide it all the way into that nodule so that I confirm that I'm biopsying thyroid nodule, not normal thyroid gland. And we would pull some cells out from that nodule. We prepare it and send it to our pathologist, and they give us an answer in a few days of what the risk of malignancy would be in that case. So that's the whole procedure. Afterwards, clean you up, which we'll do real quick. Put a little Band-Aid over top of where we did the biopsy, and that's it. People walk out. There's not a lot of pain from it. There would be no restrictions afterwards. You can eat and drink whatever you like after the procedure. You could go to full activity. You could go work out right after you do such a procedure, and then there's no restrictions with that. So,
what about blood thinners? If someone's on blood thinners, aspirin, Plavix, some of these Xarelto, Eliquis, do you need to hold that for the biopsy, Dr. Petersen?
That's a great question that doesn't have the clearest answer. I would say under most circumstances, I would still go ahead and perform a biopsy with someone on blood thinners. If you're on multiple blood thinners and we have the luxury of having you hold them for a few days, occasionally I will bring patients back for a biopsy once they're off blood thinners for a few days. But under most circumstances, I still would go ahead and do a biopsy while on blood thinners.
Well, I tell you what, that was real informative there, and I appreciate you doing that. We're going to take one more break, and then when we come back, we're going to talk, just kind of wrap things up. We're going to talk about once we find the nodule, what is the time frame that someone should return and how often someone should come back. So I want you folks to stay tuned, and we'll be right back.
This is Doc Talk, brought to you by Plateau Medical Center.
At Plateau Medical Center, we have the newest technology, which is robotic surgery. Prior to us getting it, you would have to travel out of the area into a larger hospital. Using the robot, less pain, quicker recovery time, quicker return to normal activities, and shorter hospital stays.
This new robotic platform allows us to do what we do and do it even better, and that's only going to benefit our patients.
It's not about the technology, it's not about the robot, it's about patient outcomes.
This is Doc Talk, brought to you by Plateau Medical Center. And now, Dr. Paul Conley.
Welcome back to Doc Talk. I'm Dr. Paul Conley, and we are here with our guest, Dr. Andrew Petersen, who just, as you witnessed, just did an ultrasound of my thyroid, and it looks like I may have a little small early nodule there. So tell me about that. If someone does have a thyroid nodule, and you look at that and you see that it has these benign features, how often should one follow up with you, and how often should one have an imaging test?
Sure. So based on the size and the look of the nodule, like we discussed, and the results of our biopsy, we kind of put you into these categories of benign versus concerning for malignancy categories. Benign nodules we would follow with serial ultrasounds, where we're watching for its growth and its changes in size over time. We usually do ultrasounds on a yearly basis until it shows stable growth. And that's what we would do with a benign nodule that is of a smaller size, less than 4 centimeters. If we got more concerning results on our pathology, that there's suspicion for a malignancy, we would talk about thyroid surgeries and how we would fully diagnose that. And we would usually do that with one version of thyroid surgery that usually includes either total thyroid gland removal or partial thyroid gland removal. And depending on multiple things, we would decide about that. Those are all things we would talk about during a consultation. I do thyroid surgery frequently, and it has moved into a phase of less invasive, less trauma surgery, where we try to make it as easy as possible and get patients recovered easily and back to their lives with little recovery and nuisance into their life.
Well, I tell you what, it looks like we're running out of time, and I really appreciate that, and maybe even another segment we can even delve into more about thyroid surgery. I do know that, with you being here, it's been great to have you on campus, and, thyroid cancer is something that, is most easily treated. It's something that, the risk of surgery is low, and basically it's curative. And I think that's what's so impressive about what you just showed us today, is that we can go from a thyroid nodule to the workup, and then if there is a cancer, someone like yourself can go ahead and remove the thyroid cancer, and the patient can have a great outcome.
Absolutely.
Well, Dr. Petersen, I tell you what, you've been very, very informative with thyroid disease, thyroid nodules, and I just want to tell you I really appreciate you coming on the show tonight. And for those of you watching our broadcast, we appreciate you. And until next time, good night.